Hello, and thank you for joining this OncLive TV peer exchange, a prostate cancer update on clinical practice, biomarkers, and urologic practice management. This program will feature expert insight on the incorporation of new service lines into a large urology group practice. My name is Raoul Concepcion, and I am the director of the Advanced Therapeutics Center at Urology Associates in Nashville, Tennessee. Participating today on our distinguished panel are Dr. Richard Harris, Chief Executive Officer of UroPartners in Chicago, Illinois, Dr. Gary Kirsch, President of the Urology Group, Cincinnati, Ohio, Dr. Neil Shore, Medical Director, Carolina Urologic Research Center, Atlantic Urology Clinics in Myrtle Beach, South Carolina, and Dr. Sandy Siegel, Chief Executive Officer of Chesapeake Urology Associates in Baltimore, Maryland. Thanks again for joining us today, and let's get started. Currently, many large urology group practices are interested in expanding the breadth of services that they can provide for their patients. What we'd like to do is to really talk about what some of these new opportunities are, especially as we get into the world of a difficult environment of diminishing reimbursement, and more importantly, as we move away from the traditional payment model of fee-for-service. You know, we all know that the government wants us to move away from that model. We all have incorporated, I think very successfully, integrated practices for the better care of our urology patients. So I think one of the key opportunities, and there was actually an article in the Wall Street Journal yesterday discussing the use of multiparametric MRI and fusion biopsy in the diagnosis of prostate cancer, and how that probably will become state-of-the-art, standard of care. There's going to be a lot of debate about that over the next couple of years, actually over the next few months. But I know many of you have already started to incorporate that. So, Sandy, you're over in Baltimore. You've got a very competitive market with the University of Maryland, Johns Hopkins, you guys. You've had this in place for now, what, the better part of a year, correct?
Well, 2.5 years now.
Okay.
And when I initially looked at our treatment of prostate cancer patients and prostate biopsy patients, I did not think they were getting the optimal care. I felt that some were getting lost to follow-up. There were some diagnoses that weren't being followed properly, like atypia on a prostate biopsy. And I was looking for opportunities how we could take care of these patients better, follow them better, and get better diagnosis from them. I had a conversation with Herb Lepore, who's the chief of urology at NYU, and he was starting with a process that is the MRI, today the MRI fusion. And I went up to visit Herb, watched him perform this, and then I sent some of my doctors up there to learn the process and bring that to Baltimore. So about 2.5 years ago, we started the process, and now we've done close to 500 men with this. I think the advantage to us was that the diagnosis of atypia, which I'm sure we'll discuss in a little more detail, was being lost to really good follow-up. We were looking for a diagnostic technology, diagnostic test that could help us identify men who were not identified with prostate cancer. We felt were high risk for prostate cancer, but could be better identified with a better biopsy technique, and that was the MRI fusion.
Yeah, I mean, I think there's no question that we have been doing biopsies the same way since basically the 1990s. And to me, I've always felt that what happened during that time frame, there was a perfect storm that took place. There was the incorporation of PSA into routine clinical practice, but also what came about was the ability for the urology practices at a relatively inexpensive rate to purchase ultrasound equipment. I mean, it just was not that prohibitively expensive. But also what became important was the ability to, through the ultrasound probe, be able to perform a biopsy, which was far, far superior than what we had done in the past for those of us, because I think we all trained about the same time, was the old transperineal triangulation method, transrectal method, using a 14-gauge Vin Silverman TrueCut biopsy technique. But so that technique has been around, but Neil, from a clinical standpoint, so what's been this push from a clinical standpoint? Why do we need to move into this?
Yeah, You know, let me take just a little step back. I love the fact that you brought up the issue of ultrasound, because I think we are all of the same age when we trained in our residency, where people started to say, hey, you're going to have to learn ultrasound. And many of us were like, ultrasound? It's a disruptive technology. We're not going to learn that. And then Dr. Cooner in Alabama and his courses and our European colleagues were way in the forefront of that. So disruptive technologies like MRI, which clearly have the potential for greater sensitivity of where to direct your biopsies, perhaps avoid biopsies, find higher index lesions, is really clearly beneficial. The challenge right now is we have to promote the best patient care, and yet we have these heterogeneous markets. You know, in Sandy's world, he's competing in a large metropolitan area with big tertiary centers. Where I am in Myrtle Beach, my nearest academic competition is several hours away. And that probably speaks very clearly to a lot of the large urology group memberships. We have different issues that affect our markets. But that said, the most important thing, and Sandy said it, is we have to do what's in the best interest of patients. Some of the challenge with MRI today is that the data is mostly single institution. There's several different vendors. And then let's make no mistake about it, our reimbursement model says it's more cost up front, and there's no reimbursement methodology for that extra time. So a lot of our colleagues are saying, hey, you know, why am I going to do this? Well, they said the same thing about ultrasound as you said. And so I think that this clearly has to be embraced. The large groups have to embrace these newer technologies, such as multiparametric MRI.
Yeah, and we know that from the pathologic standpoint, with traditional sextant ultrasound-guided biopsies, or sampling less than 0.5% of the prostate, we know there's sampling error. We are obviously embracing, rightfully so, this concept of active surveillance. So to that end, I think we do have to identify these patients, and I think there's going to be complementary technology of MRI as well as biomarkers. But I think you bring up a good point, is that this is disruptive technology. I think it is important as the urologist, as the specialty that I think all of us believe we need to continue to be the controller, the engineer of prostate and its disease, prostate cancer. I think it's paramount that we incorporate this into our practice, and I think there's lots of opportunities that give the urology groups a chance to really answer some critical questions that are going to need to be answered. Now, Richard.